Thank you. That's a pretty hard act to follow, Dr. Ponsky. So this is more about during liver resection and bile leakage during liver resection, but I did put both the common bile duct and more major bile duct injuries in addition to the liver resection. But what I thought I'd start off with is the official definition of a bile leak, which is the bilirubin concentration in the drain fluid of at least 3 times the serum bilirubin concentration after or on postoperative day 3, or the need for radiologic or operative intervention resulting from biliary collections or bile peritonitis. All right, so that's just something to keep in the back of your mind. So on day 1, it doesn't count yet as a bile leak. And so the 2 types with a bile duct injury versus an unidentified source from the hepatic transection. And Dr. Ponsky talked about this already, so I'm gonna go fairly quickly. And this is really some of the injuries that occur from either aberrant anatomy or, as Dr. Ponsky pointed out, where you're looking at a field and you get disoriented and you may mistake structures for different structures. And so as he pointed out, you know, stepping back, taking a minute to re-examine everything, maybe even calling in a colleague or potentially converting to open. There should be no shame in converting to open. I know it sometimes gets this bad label of oh my gosh, you converted. But the reality is do whatever is safest for the patient. And here are just some of the anatomic biliary variants that also Dr. Ponsky touched upon. And so what I would say here for those, you can either do a direct repair. I personally like, if it's a partial transection, is talking to your endoscopic colleagues about putting in a covered metal stent. So in the OR, you leave a drain and then you let them put in a covered metal stent and you let that injury heal over that covered metal stent. You may end up with a stricture that they can balloon dilate open later on, but you might be able to, you know, avoid having to do a Roux-en-Y hepaticojejunostomy. What about the small duct injuries? And this is really where I'm going to spend most of my time. So when you look back at what is the incidence of a bile leak, and this was a paper that looked at about almost 7,000 liver resections through the NSQIP database, and it was about 7.7% of liver resections had a bile leak. It was lower for minimally invasive versus an open resection. And some of the risk factors, people have tried to come up with risk scores as to whether or not you're going to end up with a postoperative bile leak, but I think the reality is that there are a lot of factors that come into play. And some of that is the actual health of the patient and the health of the liver. And so these are some of the factors that have come up in multiple studies as risk factors for having a bile leak, including, you know, poor nutrition, an increased BMI with steatosis and steatohepatitis, an open versus an MIS, prior hepatic or biliary resection. We all know those are a lot harder and it's a lot easier to get disoriented. Major hepatectomies, some non-anatomical liver resections, intraoperative bleeding and transfusion. As Dr. Ponsky said, you know, if you end up with a field full of blood, that sometimes people panic and start putting clips all over the place, and then you end up making a situation much, much worse because you get disoriented. And increased OR time, but sometimes the increased OR time is just a reflection of the increased complexity of the operation. And so I thought this was interesting. This was an animal model study, and what they did is they injected the cystic duct into the common bile duct and tried to get to evaluate the pressures it would take to open up what had been sealed by either a ligature, a ligaclip, or a harmonic scalpel. And you can see the different pressures that are needed. And so, you know, the harmonic scalpel is one way that you could potentially close a small bile leak if you can identify it. And so, how do you find these bile leaks other than looking at the cut surface of the liver? Because sometimes it's not as easy to identify. And the intraoperative cholangiogram via the cystic duct is really a great way to do this. I tend to use air more so than any methylene blue or ICG, because the problem is once you use the blue or the ICG, you can only do it once because then the field is really contaminated and it's really hard to see where the leak is. Whereas when you do air and you have some saline in there, you can see where it bubbles out. You can also do the gauze test, but that sometimes is not as easy because you peel away the gauze either minimally invasively or open, and then it's hard to know exactly where you were. And when you look at the utility of the intraoperative cholangiogram, this was a nice study where they basically did a meta-analysis of multiple studies together. And you can see that if you do an intraoperative cholangiogram, the post-op bile leak rate went down to 4% versus 12% in the control group where they didn't do one. Their overall morbidity was also lower. The need for intervention was lower, and the length of stay was lower. So these were all statistically significant. So I think that there is utility to doing this, and it does take a little bit of extra time, and you do have to take the gallbladder, but in many liver resections, we're taking the gallbladder anyway. And make sure you leave your cystic duct stump long so that you have the ability to put your catheter in, because you will be putting some traction on the cystic duct, and the more length you have, the easier it is to do that. And so Dr. Ponsky already went over some of this in terms of, how are you going to seal this bile leak? You can do a direct repair either with a ligature or a clip. I personally like the clip the best because I feel like it's the most secure because you can see it and you can try to get that to seal. You can put a stitch in. You can consider drainage only if it's a very, very small bile leak. And obviously you always need to check the drain bilirubin before you remove the drain. And there's always a debate about bulb suction versus gravity. And I can tell you, Murray Brennan sort of put it into my head about if you put a bulb to suction, you're creating a fairly large negative pressure system, right? And bile flows in the path of least resistance, just like the pancreatic fluid flows in the path of least resistance. So I am a proponent of gravity drainage over bulb suction. And what about sealants? So there really is no good data on the sealants, and I will tell you that there are a lot of fibrinolytic proteins in the bile, and so they break down all of these sealants. So that may not really be, it may give you a false sense of security, saying, okay, well, I'm just gonna put this all over the cut surface of the liver and it'll be fine, because there really is not good evidence that that will help. And what about to drain or not to drain? So there's a nice multi-institutional randomized controlled trial from 7 Japanese centers, and they looked at over 400 liver resections, open and MIS. And you can see that drains should not, there was no benefit to placing drains after uncomplicated hepatic resections. So I think that if you do not see a bile leak and you have a straightforward hepatic resection, there really is no role for placing a drain. So in conclusion, treatment of bile duct injury depends obviously on the degree of the injury. Have you injured the main right or main left or the common bile duct versus a peripheral duct? Intraoperative bile leak tests should be considered because there is data that it's associated with a reduction of post-op bile leak, overall morbidity, and need for a re-intervention and length of stay. And drainage is associated with increased morbidity after uncomplicated liver resection, so please don't routinely put in a drain. Thank you.